Good afternoon, and thank you for joining us. My name is Brian Johnson. I'm a member of the University Hospital's Marketing and Communication team. I'll be the moderator for our virtual health talk this afternoon, in addition to Kelly Crow and Margaret Vogel, who are assisting us with this event too. We appreciate you taking the time to join us during Breast Cancer Awareness Month for our health talk today on what to know about risks, screening guidelines, and survivorship. We are joined today by our medical director of the Hampson Mole Breast Health Suite at University Hospital's Elyria Medical Center, Dr. Keith Warner. Before we begin, we have a couple of housekeeping items. In this platform, all attendees are muted. While you will not be able to ask questions through your microphone, please note the Q&A function at the bottom of your screen. If you have a question that is not addressed in our presentation, please submit your question through the Q&A feature. Our physicians will answer questions at the end of the presentation. Also, this afternoon's webinar is being recorded and will be available for viewing on demand in the near future. It will be posted on the University Hospital website, and as an attendee of this afternoon's session, you'll receive an email after the event that has a link to the presentation. It is now my pleasure to introduce you to Dr. Keith Warner.
Good afternoon. For those of you attending, thank you for your presence. It's an honor to be able to present the health topic today in our Breast Cancer Awareness Month on behalf of the Breast Health Services of University Hospitals. As Brian mentioned, thank you, Brian, I am in Elyria. What you see on your screen represents the compelling reason to continue to be vigilant about breast cancer, despite the fact that in the past 50 years, there has been greater than a 20% decrease in mortality from breast cancer. We still see greater than 230,000 new breast cancers annually, and there are 40,000 deaths in this country. The lifetime risk in this country is approximately 10 to 12%. For the individuals between ages 30 and 40, that risk is approximately 0.4%. For individuals between 40 and 50, the risk is approximately 1.5%. So the 30-year-olds, 1 in 227, the 40-year-olds, 1 in 68, above 50, we get into those the highest risks. For premenopausal women, age makes a lot of difference. Under age 25, it is not unheard of. There were it is not unheard of, but it is extraordinarily rare. There were about 1,000 people, women, in 2017 who died from breast cancer. Most of those were over 25, but a few were not. Then you've all encountered, as we consider the risks of the premenopausal women, that you've encountered the statement about dense breast versus non-dense breast. Dense breast referred to, non-dense breast referred to fatty breast, but for a comparison between the dense breast and the non-dense breast, the fatty breast is about 4 times the risk of a breast cancer diagnosis over a lifetime. In the premenopausal women, the number of first-degree relatives also leads to concurrent increasing risk. And having had a breast procedure is associated with approximately a 50% increase in risk. Now, that doesn't mean that the prior procedure precipitated that risk. It probably encompasses some of that to a very tiny degree, but the predominant effect seems to be related to the fact that abnormal findings lead to procedures, and therefore abnormal findings are also associated with that 50% increase in risk. In the postmenopausal women, there are the age factor is still operative, but we have noted that there are ethnicity risks. The Caucasian American female and the African American female have the highest documented risk. Hispanic ethnicity is associated with a 30% risk in reduction, and Native Americans are 44%, Native Americans and Pacific Islanders are 44% reduction in risk. For those patients in postmenopausal range with breasts with high density, there's a greater than a 3 times risk. And for people who have a mammogram that is identified as an abnormal finding suggestive of a cancer, but it turns out not to be a cancer, there is about a greater than 2 times risk increase in the subsequent year. So this common statement about breast density, parenchyma is tissue. It's, you know, a nice fancy medical word for tissue. So breast parenchymal density for the, oh, there you go. This first picture is a completely fatty breast. And you're able to see in this picture, my mouse went, okay, there it is. You're able to see the suspensory ligaments of the breast. This is the fibrous tissue within the breast, the suspensory ligaments of the breast. And in the adolescent, these are really, really prominent. They actually provide the support of the breast, and they're attached to the chest wall. You may even be able to see, I think this is a blood vessel that's running in the breast. You can see the blood vessels, and the blood vessels are not necessarily calcified as in older people. You just can see them because the breast density is not so great. You can see little areas of calcification. On the opposite end, in picture 4, this is a very dense breast, and you can see the parenchyma, or the tissue of the breast, is just whited out by the X-ray process. In this picture, the X-ray penetrates the tissue very poorly because there is a very intense amount of fibroglandular tissue. This one has some fibroglandular tissue. This has more fibroglandular tissue, and this has very little fat and is mostly fibroglandular tissue. In this third picture, you see some of the same suspensory ligaments that you see here, but they're almost amplified in thickness and density, reflecting and obstructing the passage or transmission of the radiation or X-ray beam through the breast tissue. So minimally, this is a non-dense breast. This is a very dense breast, heterogenously dense breast, and then scattered fibroglandular tissue. So let me make sure that's good. We move on to talk about the epidemiologic risks. Older ages, an older age patient, as we delineated, as I talked about, both the premenopausal and the postmenopausal group. Early onset of menses, and early onset is individuals who have onset prior to age 12. The nulliparous woman and the woman who has had her first pregnancy later in life, usually after 30. The family history, hormone use in the postmenopausal aspect of life, and if the person has had a previous breast cancer. Then there is the genetic risk. And what is interesting about this is that the genetic risk is discussed a lot. What is talked about most frequently is the inherited risk. Inherited risk is relatively significantly less common, occurring only in about 5 to 10% of the women who have breast cancer. It reflects gene changes which are called mutations, and they are able to be passed down within the family from parent to child or daughter, but they also passed along to sons. The ones that you know of most commonly are the BRCA1 and 2s, and the BRCA genes are suppressor genes that interrupt continued growth of cells so that the cells do not grow out of control and turn into cancer. Having one first-degree relative, mother, sister, daughter, who has the gene doubles the individual risk. The more common occurring breast cancers develop secondary to changes in your individual's own genes. They're not transmissible from parent to child. They are the more common. So the genetic counseling is geared towards identifying those individuals who have a transmissible risk or have received a transmissible risk. And therefore, in this age of attempting to be certain that we're not wasting resources, the NCCN, National Commission on Cancer, has come out with some guidelines about how we utilize genetic counseling, recognizing that genetic counselors are not abundant in number, and today pretty well completely booked, and it's difficult. The utilization of their time needs to be conserved reasonably well to serve those whose need is greatest. So they recommend that if there is one or more primary relatives with breast cancer, you are a candidate for genetics counseling. If you have a relative who had had 2 breast cancers, or a relative who was less than 65 years of age when they got a breast cancer, and finally a first-degree relative, mother, sister, daughter, who had ovarian cancer, metastatic breast cancer, or male breast cancer. So the mother, sister, daughter for ovarian cancer, metastatic breast cancer, and if you had male breast cancer in the family, that person is of significant risk, and that first order relative then would be relative would then be father, brother, son. There are economic affiliated risks for low-income people in counties and countries, showing a doubling of the risk. And in Western countries, which we use as the standard, that risk is, as I said, between 10 and 12%. Of key significance, early detection decreases mortality. So the risks that we talked about and we'll discuss to a further degree impact the risk for developing cancer. Early detection impacts the risk for improving or failing to improve curability. If we look at non-genetic risk factors, which are commonly known or referred to as lifestyle risk factors, body mass index, obesity, physical activity, alcohol intake, smoking, exposure to ionizing radiation, diet, which probably has a relationship to BMI, and environmental factors. Physical activity, BMI, and diet all seem to have a strong correlation with the recognition that physical activity, exercise of at least 150 minutes per week, has a powerful relationship to improvement in outcome for the individuals who are diagnosed with breast cancer, showing a decrease in mortality of up to 40%. Alcohol intake in the premenopausal woman patient is pretty difficult to provide a consistent analysis of what outcome can be expected. However, we know, or have been able to discern, that limiting alcohol to 1 or fewer drinks per day reduces the risk of developing a secondary primary breast cancer in individuals who have had a breast cancer. In the postmenopausal, there's a much more clear relationship that is linear showing that there is a 10% increase in incidence of breast cancer for individuals related to each 10 ounces of alcohol ingestion per day. And if you are on hormone replacement therapy, the risk of developing a breast cancer doubles. The strong relationship with smoking. Current and former smokers have a 16% increase in risk versus, as compared to the general population, versus a 9% decrease in risk for those who have never smoked. The highest risk are in people who have had a 50-pack year history, which essentially means if you smoke a pack of cigarettes per day for 50 years, or 2 packs a day for 25 years. The risk persists for up to 20 years after discontinuing smoking. And for those who quit smoking after diagnosis, there is a higher overall survival than those who continue to smoke. That raises a question which we'll address in a moment. In today's world, exposure to ionizing radiation is reduced as compared to what it was like 25 years ago. But women who are exposed to radiation, ionizing radiation, between ages 30 and 40 show a particular increase in risk. And that radiation is usually a result of treatment of some sort, for instance, treatment for thyroid cancers. Dietary issues and their impact on development of breast cancer. The Western style diet, which is high processed ingestion of processed grains and meats and red meat, versus the prudent diet, which is high in fruits, vegetables, whole grains, chicken, etc., have exactly the same incidence of breast cancer among both of those populations. However, for the individuals consuming the high dietary fat diet, they have a increased cancer mortality if they develop a breast cancer. The soy products have been promoted in lay literature. They have not been found to have be associated with an increase in breast cancer. There is some suggestive evidence that they may be associated with a decrease in breast cancer. Vitamin supplementation. Vitamin C reduces has been associated with a reduction in breast cancer mortality. Vitamin D levels that are low are associated with an increased risk of breast cancer mortality. Vitamin E makes no difference. And maybe this is may be perceived as a plug for the Sun Belt, but what's been discerned is that there is a lower risk. The lowest risk in the country seems to be the individuals who live in areas where there are higher annual levels of sunshine. So many questions remain unanswered, and here are some of them. Does weight loss after the diagnosis improve survival for the overweight patient? And we don't know the answer to that. Can reduction in dietary saturated fats or high dietary fat, dairy fat, sorry, improve prognosis? Do the soy isoflavonoids actually protect against recurrence? Does quitting smoking after breast cancer result in decreased breast cancer mortality? Or I guess the corollary to that is the difference that is noted between those who quit smoking and those who continue smoking due to the fact that you didn't quit smoking but continued, and the mortality increased or didn't actually decrease. What is the weekly limit of alcohol consumption for patients with breast cancer? We don't know the answer to that. We know only what I said before, and that is that continuing to ingest ingest alcohol has been associated with a somewhat greater risk of breast cancer recurrence. How much, we don't know. And vitamin C and D supplementation, do those actually reduce the risk of a recurrence in the distant future. There's a lot yet to be winnowed out about the data that I showed you, but I think that we're able to come up with some guidelines that have been helpful from the data that I did discuss. Screening guidelines. Throughout university hospital systems, we use the American College of Radiology and the Society of Breast Imaging Screening Guidelines. We follow those at the Hampton Mole Breast Health Suite here in Elyria. And the guidelines say that at age 40, women should have their first screening mammogram. And these guidelines are for women with the average risk of breast cancer. They don't relate to the persons who are at high risk, like the ones with first order relatives with breast cancer and the ones with known genetic mutations. First mammogram at age 40, annual screenings thereafter, and those should be associated with an annual clinical exam. At our breast health suite, we try to arrange so that the examination and mammogram are performed on the same day. And what should be understood from for everybody undergoing a mammogram is that the mammogram provides imaging that provides guidance about a need for further investigation of changes. And there are a number of changes. The mammogram doesn't protect you from breast cancer. It only identifies what's there. It also doesn't increase your risk of getting breast cancer. The radiation exposure is minuscule. There are the annual mammograms that were traditionally done until about 2 or 3 years ago in most institutions. Here at the Hampton Mole, until about a year ago, and throughout university hospital systems implemented 2 to 3 years ago, were the digital mammograms and implemented, as I said, about 3 years ago, the 3D mammograms. Both of those are done routinely at your screening study. There are 28 locations at which university hospital systems provides this service throughout northeastern Ohio. And for the individuals with dense breasts, that completely white block of tissue, which doesn't allow for penetrating evaluation of the internal structure, we offer throughout university hospital systems the option for a fast MRI. Now that's a self-pay study. For the individuals at high risk that have been documented from personal history, family history, previous biopsies that show high risk, those individuals are often able to obtain insurance coverage for standard MRI studies. And what's recommended for the high risk group is that you get regular annual mammograms alternating at the 6-month period with a standard MRI study. That's a very expensive study. For the individuals who have dense breasts, no other evidence of a high risk issue, we offer the fast MRI that gives us an equivalent diagnostic capability to the standard complete MRI, and at a fraction of the cost, maybe less, 10% of the cost of the regular MRI or less. The key benefit to screening is early detection. Early detection results not only in a significant improvement in survival, but a significant improvement in the options for treatment that allows for saving of the breast tissue. It's called, we call it breast conservation surgery. It's commonly known as lumpectomies. We utilize techniques like hidden scar procedures that leave the appearance of having had something done as either minimally detectable to really pretty much undetectable. And the breast conservation procedures are accompanied in most cases by the addition of radiation treatment to the remainder of the breast. Not the additional breast, just the one in which the cancer was found. So that tells us quite a bit about risk and assessment. I briefly touched on treatment, but treatment is a huge and complex discussion and really deserving of its own place and discussion in a separate session. What is cogent is that after your treatment is completed, you now have gone from excessive monitoring, excessive intervention, weekly, monthly intercession with medical providers, and you've come to the end at a year later, and it all stops. And you've had a bewildering exposure to treatment and medical intervention, and now you have lots of questions about what do you do. You should receive a survivorship care plan, and the survivorship care plan is provided either by your medical or radiation oncologist or cancer surgeon, and it is a written summary of your diagnosis and treatment. It should be complete, and it allows you to be able to transport or transmit that to future caregivers, inclusive of your primary care caregiver. We encourage throughout university hospital systems, and certainly at the Hampton Mole Breast Suite, we encourage our patients to be able to be capable advocates for themselves. The questions that we aid in designing and providing answers include types of breast imaging and scheduling, follow up with physicians and other appointments, and reminders as needed, and where to seek assistance for side effects of treatment regarding, particularly regarding recovery. And finally, there are cancer recovery support groups, the ones that we've found to be most effective in the process of survivorship, rehabilitation back into your normal lives, in provision of provision of supportive materials such as garments, prostheses, exercise, physical fitness programs, dietary. The Gathering Place has been a terrific place, and it's a place where where survivors have a chance to meet others and interact. This is our suite here at Elyria. We work diligently to make sure that our patients in the survivorship period have the support not only of our staff and our navigators, but our physicians work vigorously to communicate with each other so that patient care doesn't deteriorate in any fashion. These are some of the kind things that have been said about us. They're commonly said at the centers that university hospitals have made available to the public. And for us at Elyria, we like the fact that we're able to bring those services from university hospitals to this community. Thank you very much.
Thank you, Dr. Warner. This information has been very helpful to share, and we appreciate you taking the time to do this. For the audience, this is the beginning of our question and answer session. We did have some questions coming in, and just as a reminder, if you have a question, you may type it into the Q&A function at the bottom of your screen. Our first question coming in, Dr. Warner, is a question related to the screening. Her question is, what's the recommendation for screening for a bilateral mastectomy with silicone implants?
That depends on a number of things. For the individual who chose to have a elective bilateral mastectomy and did not have bilateral breast cancer and does not have a genetic reason for having had the contralateral breast removed, the screening can be related to the stage at which her cancer was diagnosed. For early stages, what I showed earlier with 3 to 4 months, 6 month monitoring by oncologists, radiation oncologists, and surgeon in the first year of post-treatment, and then 6 month or annual follow-ups appropriate. Mammograms, I am certain that a large component of that question relates to what do you do for imaging? And obviously mammograms are not going to be useful because if the reconstruction was with implants, then you'll see implants. If the reconstruction was with native tissue, that native tissue is usually moved from the abdominal wall, and sometimes it's moved from the back, the latissimus dorsi muscle and the overlying fat. The latissimus dorsi muscle is that muscle that the Bowflex boys exhibit by putting their hands on their waist and flaring the back out. So that can be moved over onto the chest wall. Now, obviously, imaging of those tissues is not going to be reflective of breast cancer to any greater degree than they would have been were those tissues left in their native locations. So you want to examine the tissues around, and you want to examine through those tissues down to the chest wall, if that's possible. So to the degree that that's possible, it's done by examination. And if something is found or something is of concern, then ultrasound imaging is appropriate. For the person with an implant, if there appears to be something deviant, changed, or abnormal about the implant or its location on the chest wall or the chest wall itself, frequently an MR scan provides you with the best study. How often I would say for the clinical examination, an annual examination is appropriate.
Okay, great, thank you. Our next question is, she has had several breast MRIs, but has read that the contrast agent could be dangerous and accumulate in the brain. And she's wondering your thoughts about this with the contrast agent.
That is a concern. Well, maybe that's not the correct term. That certainly has been discussed, and it is recognized as an issue. The question becomes, why has that person had MR scans done? And if the MR scans are being done because of dense breasts for which there is considerable reason for suspicion, the risk of neurogenic consequences, brain consequences from the gadolinium lesser of concern and tend to be later life duration than the protective benefit that the MRI provides you regarding breast cancer. Recognize that breast cancer is the most common cancer and found in women in this country. And it is the, and certainly in the premenopausal woman, it is the most common cause of cancer death.
Okay, our next question is also related to the fast breast MRI. Her question is that she had the procedure and then afterwards she noticed she had a bruised rib for a few weeks after the procedure. I was wondering if that is common.
No, it's not common. The MR scans for the breast are often done in the supine position, lying on the tummy. So the breasts then have to go into breast holders, and that the injury to the chest wall, or injury to the chest wall may occur because of an effort to get the person further into the MRI cups, or the fact that the MR cups are elevated into the space, so they press into the chest wall more than than is comfortable. It's not a common occurrence, but it does occur. It's not what we want. We find it undesirable, but it doesn't have a long-term consequence of that is pathologic.
Okay. Our next question is she's having some pain under her arm near her breast and has a mammogram scheduled this week. And she wanted to know if she should tell the technician about that pain that she's having under her arm near her breast.
Yes, the technician should be told, but probably the wisest choice would be to notify the person who has ordered the mammogram, because if that physician ordered the mammogram and was unaware of the pain, then they may want to investigate why you have that pain and be able to decide if something different needs to be done or something additive needs to be done at the time of your mammogram. If the order for the mammogram was issued with the awareness of that pain, then that should be included in the requisition that's delivered to the radiology, because it is likely that the clinical person who will provide your mammogram is a technologist, not a physician or a nurse practitioner or somebody like that.
Okay. And our next question is, does the physician who orders the mammogram, do they need to specify the 2D or a 3D mammogram, or can she request to have the 3D mammogram?
You can certainly request to have the 3D mammogram, and my understanding is that today, both digital imaging and 3D imaging are approved and covered by insurance companies, to the degree that if you are referred in the university hospital systems now, if annual mammograms are ordered, the 3D mammograms are included as a component of your mammographic imaging. So you get both types automatically.
Okay. I know you touched on this a little bit earlier related to dense breast tissue. This question is, she's been told she has dense breast tissue and wants to know your recommendation for what type of mammogram or imaging should she get?
The mammograms that are available are 2D imaging and 3D imaging, both of which are going to be limited in the penetrance of the X-ray into dense breast. To the degree that that penetrance is significantly compromised, the study that will enable a more exhaustive and very thorough answer will be MR scanning.
Okay, and we have a question regarding, she's noticed a burning sensation in her breast, and she wants to know if she should be concerned and get it checked out.
The answer is yes. In many cases, the burning sensation is not very well characterized, or investigation doesn't, medical investigation doesn't necessarily answer the question. It frequently has hormonal implications or hormonal effects. If the pain is cyclical, the burning sensation is cyclical within the breast, that is, it tends to follow a periodicity month by month, with intensity occurring at certain times and not being so intense at others. That seems that more frequently relates to a hormonal influence. A constant, unrelenting burning discomfort may imply something quite different. Most usually, pain and burning sensations in the breast do not imply any change or increase in breast cancer risk. Having said that, we know that because what I just said is true, and that is burning sensation, pain in the breast has no definable relationship to breast cancer. The likelihood of missing a breast cancer because the person's complaint was pain or burning sensation is increased, because most medical practitioners know that that's unlikely to be related to having had a breast cancer. That doesn't mean a person can't have breast cancer and those sensations simultaneously. So yes, the physician or your provider should be informed, and the investigation should occur. There is a decent chance that it'll turn out to be hormonal, and a decent chance that it will not be treated as a breast problem. And there's also a modest chance that it may be a chronic and not solvable medical problem. In almost every circumstance where that's true, that burning sensation diminishes, abates, or goes away at menopause.
Okay, well, thank you, Dr. Warner. This has been very helpful, and we definitely appreciate your time in talking with us about this today and answering all of these great questions we've received. A couple of reminders for our audience. This presentation was recorded, and you'll be receiving an email in about a week or so with a link to view the presentation again, and will be placed on our University Hospitals website, uhhospitals.org. To schedule a mammogram online, you can visit our website at uhhospitals.org/mammogram. Again, that is uhhospitals.org/mammogram. We have 28 locations throughout Northeast Ohio to receive a mammogram close to you. This concludes this afternoon's event. On behalf of the team here at University Hospitals, thank you for attending, and we hope you will join us for future health talks. Have a great day.